Hello, my name is David Kooby. I'm a surgical oncologist with Emory University and the Winship Cancer Institute in Atlanta, Georgia. I focus on gastrointestinal malignancies and primarily on foregut malignancies, which would include malignant tumors of the benign and malignant tumors of the liver, stomach, pancreas, and intestines. As a surgical oncologist, I'll often get asked by my patients, can the operation be done using minimally invasive techniques such as laparoscopy or robotic surgery? And then the other question I'll get asked, not infrequently, is can surgery cause tumor to spread throughout the body? They've heard perhaps, quote unquote, an old wives' tale that surgery has an ill effect on tumors. So I'll tackle the second question first. I remember being a fairly junior attending at Emory and getting a phone call from a New York Times reporter asking me, I'm writing an article on cancer surgery suggesting that it can cause tumors to spread throughout the body. Can I say that's true? And it was a really interesting question to get. I don't know why I got the phone call, maybe because we're in Atlanta and CNN is here and my name came up somehow. But I said, you really can't say that. Sure, anything we do in life, if we do it improperly and poorly, can result in a negative outcome. The reality is, I think the concern of surgery causing tumor to spread throughout the body probably originated from the fact that we didn't have very good imaging 30, 40 years ago. And so the story was patients were opened up with a plan to remove a tumor. The surgeon probably found more advanced disease, opted not to remove the tumor, closed the belly back up, and shortly thereafter the patient died because they had more advanced disease going in. Certainly, I think if you, in the operating room, take a tumor and chop it up and leave it in the belly, I'm sure that's probably not good for the patient. And I think you can cause tumor to spread that way. But I think if you use good, sound surgical principles, then the reality is that it really shouldn't cause tumor to spread. And the truth of the matter is tumors have their biologic behavior. And you have an aggressive tumor type, then no matter what you do, medically or surgically, that tumor eventually will progress and probably result in a shortening of the patient's life. So we have to do things thoughtfully when we go into the operating room or when we start the process of treating a patient. Some of that is understanding what tumor type, and even within an organ, such as a small bowel carcinoid or a pancreatic neuroendocrine tumor, there is such variability in what each of the tumors will do and how they behave. So, we break neuroendocrine tumors up into well-differentiated, which are low risk, and then sort of an intermediate risk, and then the higher risk tumors. The highest risk tumors are going to be known as the small cell tumors. And those are the most aggressive neuroendocrine tumors that we'll face. They typically respond very nicely to medical or chemotherapy initially, but then they come back. Many of those cases will never come to surgery, and surgery may be resolved or reserved for going after something that's causing symptoms, such as involvement of the gallbladder causing cholecystitis or bowel obstruction or something like that, without the goal of necessarily completely removing the tumor. And sometimes we will find out that it was a more aggressive tumor type after we've already done the surgery. So understanding the biology of the tumor and using good principles are probably paramount for doing good cancer surgery and advising our patients properly. And, extremely important to have a good multidisciplinary team. And we discuss many of these cases at our tumor board before we proceed with surgery and outline a proper plan of care for each patient. So coming back to the first question was, should all of these cases be done in an open manner with a big incision, or are some amenable to more of a minimally invasive technique? One of the things that I've played a role in helping champion in specifically pancreas surgery is the minimally invasive technique for removing tumors of the pancreatic body and tail. The initial studies that were published really looked at saying if it could be done. And so what we contributed as a clinical trials group is we asked the question of, should it be done? And so we were able to do things in a multi-center group study, a few of them that we compared open and minimally invasive approaches to removing the distal pancreas, including tumors such as neuroendocrine tumors. And what we demonstrated was that the results showed shorter hospital stays and less blood loss and fewer complications. But then in subsequent studies, we also showed that we obtained adequate tumor margins, adequate node dissections, and that survival was not adversely affected. So the simple answer is, I think that if you are thoughtful in how you proceed and you have good sound surgical technique and have the ability and the training and expertise to do these cases minimally invasively, I don't think it's wrong to do it. I think it actually can provide great patient benefit. Now, there was a consensus statement published in 2018. I was invited to this group to be part of it, and I was not available at the time, but I've read the consensus statement. It's quite good. And it talks about all aspects of surgery. So if we're going to be doing surgery to remove a small bowel neuroendocrine tumor, one of the concepts is you need to run the small bowel from beginning to end very carefully with a thorough palpation of the bowel, because in as many as 20-25% of these cases, these tumors are multifocal. And ideally, you'd like to remove anything and everything that you can at one operation to minimize the need for additional operations and to provide best patient outcome. Also, a reasonable percentage will have disease outside the small intestines in the peritoneal cavity or in the liver, and you may not see that on imaging preoperatively. And if you do the case minimally invasively, you may not have the ability to touch all the different surfaces. The flip side of that, though, is when you have the belly open and you're looking straight down into the belly, you get a perspective. You may not get the same perspective that you will with a laparoscope or a robotic scope, where you're actually you actually have the ability to see underneath organs and unusual views that you will not get with open surgery. So I think there is a trade-off aspect. Certainly, if the patient has the right body habitus, you can make a small incision, you can bring the bowel up and run it outside the body and feel it. And then I think a key point of this is, even if everything is not dealt with at one operation, and even with open surgery, it's not a guarantee that you will as well, that you're not going to just operate on these patients and send them off on their way. They need to be followed. As a matter of fact, patients with neuroendocrine tumors typically will follow as long as they're functional, as long as they want to keep seeing me, because other tumor types, after that first operation, the chance of offering them more surgery to treat a tumor such as a pancreatic adenocarcinoma is extraordinarily rare. Patients oftentimes will then present with disease in multiple areas, not be amenable to any further surgical therapy. But for the neuroendocrine tumors, because they tend to be more indolent, if we find a spot in the liver or we find something else in the belly, we may have opportunity to go after it again and affect a benefit for that patient. So if they have a less damaging first procedure and they go under close surveillance, even if something were to pop up later, we oftentimes can salvage them, and they have good quality of life and a good smooth first operation, then I don't think it's wrong to consider a minimally invasive approach in appropriate patients with appropriate expertise and being thoughtful about it.